Okay, it's precisely 1 minute past 5, so warm welcome to the virtual Grand Rounds in Radiation Oncology. Thanks for taking the time again and joining us for a fantastic afternoon, or in which time zone you ever might be. You know our program for a couple of months, and we aim to present you the latest science presented by the top speakers in our field in a very interactive format. It is happening and planned every first Wednesday of the month between 5 and 5:30 Central European Time. Many thanks to the endorsing society, Estro, Sasro, and Degro. And I'm very grateful that for this edition, also the IRO, the Italian Society of Radiotherapy and Clinical Oncology, has promoted this lecture. And also remembering you that if you might have missed or if there's colleagues which would like to learn what has been shown, it is all being recorded and it's all being available on YouTube. Today, we're going to address a topic which has gained quite some interest and relevance for our daily clinical practice. We're talking about oligometastatic hormone-sensitive prostate cancer. And at the beginning, when we started treating oligometastatic patients, the problem appeared quite, I would call it simplistic. There's limited number of metastases, we see them, we treat them, and the problem is being solved. But effectively, we've learned the more we learn, the more complex the picture became. That is in terms of imaging. How do we identify patients with oligometastatic prostate cancer, conventional imaging, MRI, PET choline, or PSMA PET? What is the treatment approach from a local perspective? None at all. SBRT only, elective lymph node irradiation. How about systemic therapy? Do we need it? Do we aim to avoid it, delay it? Short-term ADT, intermittent long-term ADT, or even the addition of RP? And then what is the endpoint we try to achieve? What is the benefit we try to achieve for our patients in daily routine? A delay of systemic therapy? Is our endpoint a biochemical one, a radiological one, or maybe a very hard one, being overall survival? I'm very happy and honored that we are having a very up-to-date discussion today, the RADIOSA trial, which has been first published by Junior Mafaso and will be presented by Professor Barbara Jereczek, the RADIOSA trial, which tested SBRT plus minus short-term ADT for hormone-sensitive oligorecurrent prostate cancer. It addresses very important questions. What is the role of SBRT alone in oligometastatic prostate cancer? What is the added value of 6 months of ADT, a short period of time where most of our patients will recover? And what are appropriate endpoints to communicate these treatment strategies both to our colleagues but also to our patients? And that has been just recently published in the Lancet Oncology a few weeks ago. You know Professor Jereczek very well. She's full professor for radiation oncology at the University of Milan. She's also chair of the Department for Radiation Oncology. She's ESTRO president-elect. And most important from today's perspective, she has been the PI of the RADIOSA trial and of many important trials. And I also like the theme, Give Me Five, Green Radiotherapy and Strata MVT. So Barbara, many thanks for joining. It's a pleasure and honor having you. And please, the floor is yours.
Hello to everybody. So I start with sharing my slides just to check if it works. I have two screens, okay, just give me a feedback. Everything okay? Great. Okay, so wonderful to be here. I'm really grateful to Professor Matthias Guckenberger and to University of Zurich for this opportunity to share RADIOSA results and also its implications on the management of hormone-sensitive metastatic, oligometastatic prostate cancer. So the study, as Professor Guckenberger said, it has been published some weeks ago, study with the name RADIOSA. I had the honor to be a PI of this study, but I have to say a big thank you to Giulia Marvaso for her commitments to this study, and she's the first author. As you see, this paper has been also accompanied by a very interesting editorial with the title Destroy or Delay. So we'll see later what SBRT and what hormonal therapy is doing for oligometastatic prostate cancer. So It is a part of the bigger project. You see that here we published, before publishing RADIOSA, we published the design of the study. So if you want to see a detail, you can see it in this parallel studies. And also some other publications on biological or imaging tasks, because the study, as I said, it's a part of the big project funded by Italian Association of Cancer Research. And RADIOSA was just one of the tasks. It was clinical, maybe the most important, I would say, part of this project, RADIOSA clinical randomized study. But then there is imaging task, and it's, again, as Professor Guckenberger said, it's really important today because we have all this new imaging and we still apply conventional and data from conventional imaging time. And then biology study, which is ongoing, and again, very important to define better what and when should we do. So at the time we designed this trial, it was 2019, the standard for oligometastatic, oligorecurrent patient was not defined. It was either observation, even only observation in some situations, or only SBRT or only ADT, lifelong ADT quite often. So we undertaken this study to compare SBRT alone with a combination SBRT and short course 6 months hormonal treatment. The primary endpoint was clinical progression-free survival, defined as the absence of new metastatic lesions between the two arms. And there are many secondary endpoints. We are still working also on this: overall survival, biochemical progression-free survival, ADT-free survival, local control, toxicity, time to castration-resistant disease, quality of life, biological investigation, evaluation of prognostic biomarkers, and then correlation among these parameters. So the inclusion criteria, again, try to be very simple. So it was histologically proved prostate cancer, castration-sensitive, hormone-sensitive prostate cancer, biochemical recurrence after either surgery or radiotherapy, with molecular imaging. So this was quite unusual at that time, that all patients had molecular imaging, less than 4, so maximum 3 lesions, either pelvic lymph nodes, extraregional lymph nodes, or bone metastasis on molecular imaging, PET scan or MRI, whole body MRI. Good general conditions, and obviously ability to sign the written consent and complete questionnaires about quality of life. So I would say real-time patients, and we all have these patients in our departments. The patients were randomized 1-to-1 to arm 1, which is SBRT alone, 30 gray in 3 fractions or equivalent schedules, or the same radiotherapy to all metastatic lesions, and 6 months of LH-RH analog. For randomization, patients were stratified according to PSA doubling time, 3 or more than 3 months, localization nodal or bone, and imaging PET versus MRI. And here you see the, let's say, the flow of the patients. So again, very, very similar to what we see in our clinical routine. The added things were questionnaires on quality of life and biological evaluation with serum and plasma collection at the baseline, at 3 months after the treatment, and then at the recurrence. We enrolled 105 patients. Some of them withdrew the consent because it was in the COVID time, so there was some issue about enrollment and patients coming up and down to the hospital. After all, we have 51 patients in each arm. Arm A, SBRT only, arm B, SBRT, and 6 months of hormonal treatment. Enrollment took part from 2019 to 2023, 102 patients considered for this analysis. The patients were the patient characteristics were quite well balanced between 2 arms. The majority of them underwent surgery, so only 10% of them, 20% of them received radiotherapy. Median follow-up is 31 months. And what else should I say on this? Okay, the initial PSA was, the median value was 8. The median PSA at the time of the enrollment was less than 2. The majority of patients had only one lesion. It was in 40% pelvic lymph nodes, in 25% extra pelvic lymph nodes, 36% bone mets. And here are the results. So as for the primary endpoint, clinical progression-free survival, the median value 15 months for SBRT alone, and all double value 32 months for patients in combined arm. Significant with hazard ratio of 0.43. The same benefit, again, double duration of biochemical progression-free survival in patients in combination arm with a hazard ratio of 0.4. So the benefit was very clear. And also we initially designed the trial for 160 patients, but we stopped the accrual after the discussion with the scientific committee of the of our ethical committee and of course scientific committee of the IRC, because we thought it's not ethical to continue the trial with such a huge difference. And this decision, this interim analysis, was approved by the scientific committee of the IRC. These are the results divided by the subgroups. Obviously, the groups are small, so it is only preliminary analysis, but we have seen the benefit in the majority of patients. There are only some patients that where the benefit of adding short hormones was not improving tumor outcome, and this was the patients with a favorable features like PSA and enrollment less than 2. Time to first treatment longer than 43 months, so let's say indolent tumors, patients with M1A disease, so extrapelvic lymph nodes, or patients with N1 disease at the diagnosis. So it may mean that patients, probably the last subpopulation, patients with some form of persistent disease, nodal disease, that then recurred after months after surgery for N1 disease. And here are some other outcomes. So solitary in-field recurrences were very rare, only 2% of patients in each group. And we've seen that addition of ADT reduced out-of-field failure from 61 to 37% in patients in combination arm. Addition of short ADT reduced risk of polyprogression. Addition of short ADT also showed a trend for lower incidence of castration resistance. Again, 14 against 2% only in patients in combination arm. So a lot of benefit in many areas. And median time for testosterone recovery to non-castrate level was 9 months. So it was only 3 months after the completion of ADT. So it was quite surprising because we are used to see quite slow testosterone recovery, but it was only 3 months after the completion of 6 months of treatment. And what is interesting and also answers the question of the editorial, destroy or delay, eugonadal progression-free survival. This is a new endpoint. We didn't analyze it. It was post-hoc analysis. So it was the clinical progression-free survival in patients with normal testosterone. And it obviously regards only patients with a combination arm. So we've seen this eugonadal progression-free survival in combination arm was not different from the clinical progression-free survival in this group, which means that actually adding ADT delays progression. It still not destroy the tumor. It destroys only what we treat and delay progression, which can be the endpoint in prostate cancer, as we know, but we'll discuss it later. So toxicity was very low as expected, especially of radiotherapy, and it was related mainly to hormonal treatment. And so the conclusion from the trial, short ADT added to SBRT significantly improved, it doubled clinical progression-free survival in patients with oligorecurrent hormone-sensitive prostate cancer, 32 versus 15 months. Treatment-related toxicity was minimal, mainly related to ADT. short and intermittent approach. So the issue here is a short treatment may be an option in some metastatic patients. Still, some carefully selected patients, favorable patients, may be suitable for SBRT alone. And the future is absolutely biomarkers and new combinations. So I invite you to Vienna next month, in 1 month actually. We'll present other 3 sub-analysis from RADIOSA. The first, I'm really curious to present it and very happy to present it, a liquid biopsy-based molecular characterization, so biology task of RADIOSA, but also quality of life and the relation between biomarkers and quality of life. So just a short comment, and then we have time for discussion and for the questions. So RADIOSA is paving the way for short-term ADT and ablative treatments in oligo-metastatic prostate cancer. These trials are changing our strategy in this disease. Metastatic cancer does not require lifelong treatments every time. We can propose short treatment here. And as in RADIOSA, these are the slides from ESTRO, RADIOSA, it was SBRT plus or minus ADT. We start to see some very similar trials with a different design, like EXTEND trial. I'm sure you've seen it, published some months ago, actually 2 years ago. So it was a different approach, but still intermittent. So not any more lifelong treatments. It was 6 months ADT plus or minus SBRT. And again, benefit and results are very similar. It was about 15 months with single modality. So either ADT 6 months or SBRT in our treatment, in our trial, 15 months PFS. And if you combine both, you have double duration of clinical progression-free interval. So very similar, very similar results in both trials. But we start to see, as I see, many trials. They are small, but they are randomized phase 2 trials, and they all go in the same direction. Here you see hazard ratio from STOMP, ORIOL, EXTEND, RADIOSA. It is always very significant result of hazard ratio from 0.25 up to 0.60. This is oligorecurrent castration sensitive. We have also similar trials, similar design for oligoprogressive castration-resistant prostate cancer. And again, some of them already published with a very interesting hazard ratio. And this new endpoint, like next line systemic treatment-free survival up to 17 months in Medcare study. And finally, last month in ASCO GU San Francisco, this meta-analysis has been presented by Chad Tang. And it includes 5 randomized trials. Now we also added RADIOSA data, so next Wolverine will be also with RADIOSA, but at that time we couldn't join. Yet here there are 5 trials, Sabre Comet from Canada, EXTEND, ORIOL, STOMP, and ARTO from Florence. All these trials randomized patients to standard of care plus or minus SBRT to oligometastasis from prostate cancer. And the meta-analysis showed improvement in progression-free survival, radiographic progression-free survival, castration resistance-free survival, and even trend with P 0.051 for overall survival. So the benefit is really clear here. And it was clear in all subgroups, including patients with untreated primaries, staging imaging by conventional or new imaging, castration-sensitive or resistant status, treatment with or without ADT. So I think that there are so many data today that I think that the direction is really clear. So we need to work to analyze further these trials. They are ongoing trials. We need to work on the endpoints. Here you see the very nice paper by Miszczyk on endpoints in prostate cancer, and we see that clinical progression-free survival is a very important clinical endpoint here, intermediate clinical endpoint for OS. And definitely we'll have new data coming from ongoing trials. You see here the list, so Platon, Presto, Starport, Stampede trial, and so on. And the last one, StarMet. What is nice here, the number. Look at the last line. It is not anymore 50 patients, 100 patients here. It is even 2,000 in Stampede 2. So we'll have this data soon. And obviously, we're also looking to the real life data. And here compliments again to the oligo-care people. Without their commitment and a huge effort, we wouldn't have this trial. So I'm really happy and I'm very proud to be able to enroll patients to be part of this group. And obviously, I have to say a big thank you to all my team. Here you see on the higher line, it's a RADIOSA people, but obviously this wouldn't be possible without the whole team of radiotherapy here in Milano. So a big thank you, and I'm here for your questions and comments.
Thank you very much for this excellent presentation. Congratulations to this achievement, to you and to the full team, indicating that we achieve the best cancer outcome if we combine most precise diagnostic, systemic, and local treatment. We have a couple of questions. I would like to start with my usual one. How did results of the trial change your practice? So when you have done the first assessment statistics, you've seen the big difference. What have you changed in your day-to-day clinical routine after the analysis?
Yeah, this is a very good question, Matthias, and very sensitive one, because we did a lot of, and we still do, a lot of SBRT alone. We have a lot of patients asking to avoid ADT, but today we have the data, and as I said, we even stopped enrollment before the final number because we thought it is not ethical to continue with such a huge benefit. So today we discuss with the patients, every time we see patients for SBRT, candidate for SBRT, we discuss the benefit of ADT, and we make this decision together. So it was really life-changing or practice-changing trial for us.
When you say practice changing and the benefit, what do you communicate to the patient? You have had a large number of assessments. You had biochemical relapse-free survival, clinical relapse-free survival. There was castration resistance. There was polymetastatic disease and overall survival. If you go to overall survival, obviously follow-up with 30 months is being short. I think it was only 2 patients which have been dying overall of prostate cancer, and 6 deaths overall. So what is the benefit you're communicating to your patient?
Again, Matthias, very good question. I think that we don't discuss overall survival because we know that it's indolent disease. We know that they have many options ahead. And actually today we have to manage, the anxiety of cancer patients. We know that prostate cancer patients, they usually have very good prognosis. So we don't speak about, survival immediately after when we see the patient. We discuss the need for the treatment. So progression-free survival, what does it mean? That if it is long enough, the patient will have this 30 plus months with doing no treatment actually. So patients, what they want today, they have normal life. They want to avoid, visits to the hospital and so on. So we discussed that if we do this short investment at the beginning, we do it now to gain some months or even years, in this case, of progression-free survival. So I say, pay now, play tomorrow.
There's a couple of questions. Oh, please.
Yeah, this is the discussion we have today. Sorry.
There's a couple of questions in the chat. One is obviously about subgroup analysis. You've shown the forest plot. So are there any kind of parameters which would convince you to, well, that might be a patient which I can treat with SBRT only, or that might be a patient where we have to add short-term, maybe even long-term ADT?
Yes, exactly. We did this subgroup analysis. We are aware that it is, difficult in such a small groups to have significant differences, but still we've seen already the population that does not need ADT. And it's a patient with favorable features like a low PSA, long interval from the primary treatment, and patients with lymph nodal disease. So if it is only M1A disease, you can still discuss only SBRT. And also this interesting results in N1 patients. So imagine the patients with lymph nodal disease after surgery, and they come back to you 5 years after with one pelvic lymph nodes. And today it is even more challenging because either you do only SBRT as RADIOSA showed, or you do STORM, as STORM trial shows. Yes, so you have this discussion with the patient. You do three fractions, or you do 3 years of hormones and whole pelvic radiotherapy. What do you do, Matthias? Pelvic lymph nodes 5 years after P1 surgery, and patients coming back with 1 lymph nodes.
I mean, we try to, at least in my center, try to kind of communicate the patient the risk factor. I mean, what is the interval? What was the initial Gleason score? What is the PSA doubling time? Then also understand what is the patient willing to kind of invest at this point of time, to have a lower risk of disease recurrence, because as you said, the majority of patients will not die of prostate cancer. So it's a question of investment, of acceptance of toxicity, longer treatment, and preserving quality of life. We have patients where we're doing all in 3 years ADT, elective lymph nodes, and an SBRT, and we have many patients which are opting for an SBRT approach only.
But
There's
it's nice to have these options, yes, and to have
yeah,
the data to discuss. So today, when I see the patient like this, I just write also in my report, I discuss with patient RADIOSA or STORM, and we decide together because, if it is a young patient, it is, very recent surgery and he comes back with a pelvic lymph nodes. I'm also more motivated to propose a STORM treatment, so the whole package, and we discuss it, and it's good to have this data.
there's some more questions. One about the patterns of recurrence. Have you done a detailed analysis where the recurrence actually do occur? Because I also saw that the majority of patients will receive some local treatment SBRT in the salvage setting again.
Yeah, so you can, as we know, you can repeat SBRT, but as you have seen, patients receiving only SBRT quite often recur in a polymetastatic way. So we did this, the distinction between polymetastatic recurrence and again oligometastatic. So we quite often we retreat them if it is again oligometastatic disease, but if it is polymetastatic, obviously you do more intensive treatment.
The question is twice in the chat about the impact of the imaging upfront. Call it molecular imaging, PSMA PET versus morphological imaging, MRI only. Was there a difference in the benefit of the ADT in terms of staging?
We are doing this analysis, so I don't have the data yet, but we got much more patients with PET scan. 80% was PET scan and only 15, 20 it was MRI. So it will not be easy to compare them, but we are doing this analysis.
Another question by Dr. Ströhle. Was there a maximum PSA value being allowed at the time of trial enrollment? It was a maximum of 3 metastases. Was there an upper level of PSA?
No, there
No.
was no upper. And if I'm not wrong, the upper one was like 8. So it was not extremely high as we've seen maybe in EMBARK, it was 300. Here it was about 10, I think, the highest value.
Another question, which was also addressed in the editorial, it is about kind of destroy or delay. What is the duration you could achieve the delay? I had the impression it's about 6 months investment, 9 months until you have fully recovered again, and in the end you achieve about a 1 year benefit, the delay of disease progression.
A bit
Is that
longer, Matthias. It was not exactly because, okay, patient has 6 months of hormones, 3 months to get back his testosterone. In some cases, even earlier, we have patients that recovered after 1 month or even 2 weeks, which was quite surprising. And then, but the benefit is 12 versus 35 months. So it is more than double. I think that it's worth it. But
Mhm.
we're also doing, quality of life data. We don't have them here. And I'm curious also to see because, the quality of life, it is okay. Maybe patients don't want to lose even this 9 months of their life for the castration, So it is something very difficult to discuss and understand because every patient obviously will have different priorities.
One last question, also looking at the time, it's 5:30. What is the next trial you're designing? This has been
Oh,
absolutely informative, but I'm very confident there will be a follow-up trial. Can you inform us already?
I think it's a little bit confidential, Matthias. I'm not,
Okay,
but very similar design, and we are, now trying to launch it. So I think it is still because we are applying for the funds, so it is a little
okay.
bit confidential, but we will
Mhm.
disclose it soon.
Then maybe one very last question. You mentioned also that many patients are being treated with repeat SBLT, so in the setting of first recurrence. Were there patients which have been treated even more than twice with a local treatment approach? I can remember a couple of patients which were being kept on a local treatment for a long period of time, coming back every year, every 1.5 years. Have you observed similar patterns of recurrence?
Yes, we have these patients, like our friends coming every 2, 3 years, and they are happy. We are happy to see them happy. It may happen that you treat patients even 3, 4 times. We even re-irradiate. It may happen even the same lesion. It is rare, but it may happen. And in 1 month, also during Estro in Vienna, we'll present the series of the third re-irradiation. You see, so today with our technology and the data we have, we can really do very, very nice treatments. And again, compliments for all the initiatives also from Estro for ray radiation, because it's also a topic that was so much underestimated until a couple of years ago.
So I guess you have had a very good picture, but there's still some puzzles missing, and you will get them all in Vienna. So
Yes,
if there's
exactly.
open questions, so please join us in Vienna for the annual conference of the Astro Society. Many questions will be answered. Many thanks for joining. It was a fantastic overview, excellent discussion. And let me share some additional excitement about the next lecture, which will be happening on May 7th. So immediately after the Astro meeting, you know that we have become a bit depressive in the field of esophageal cancer after ESOPAC. And now we're seeing some light at the end of the tunnel. The Sano trial just been published a few days ago, which investigated the value of observation active surveillance following complete response after neoadjuvant approach being presented in the beginning of May. Thank you very much. Thanks for joining and wishing you a nice evening. Bye,
Matthias,
everyone.
thank you and see you in Vienna.
Bye. See you.
All of you. See you.